Hi, I'm Dr. Brooke Fukuoka, and the purpose of this short video is going to be to go over what we did with the subgrant that we received from the Idaho Oral Health Program between the years of 2018 and 2022. Before the grant existed, the way I funded this practice was I took out a practice loan, and we billed for Medicaid, we billed for private pay, and we tried to utilize those funds to be able to keep our head above water. Next, we'll look at the funding that we had during the grant. At the beginning of the grant, we upgraded our equipment. The equipment that I could afford to buy with the practice loan wasn't exactly the best equipment, and so we were able to get a lot better equipment when we got that initial grant money, which was excellent. We were also able to hire hygienists and buy hygiene equipment. It was awesome. Then you see in 2020, that's when COVID hit, and you'll see that between 2019 and August of 2020, we did get a little bit more money there, and that was very, very helpful for all the modifications and all the changes that we needed to make during COVID when we weren't able to go into a lot of the buildings. You'll see between September of 2020 and August of 2021, we got significantly less funding. The good thing about having it taper down like that was it really helped us focus and prioritize the things that we really wanted to keep and needed to keep, and we did have to get rid of some things because obviously when you get rid of funding you will have to get rid of some of what you are doing, and so that really helped us narrow down our vision and focus exactly on what we thought was the most important. Our total award for the entire 4-year grant was $247,000, and I believe that was money very well spent, and we'll get into that in the subsequent slides. After we ran out of grant funding, then we were like, we need to continue this program. This program is helping so many of these residents, and it's helping them so much that I just couldn't stand to have the program stop. So I funded it personally. Currently, I'm funding it personally. Well, I don't know when you're watching this video, but as of April of 2023, I'm funding it personally through my speaker honorariums, and we are partnering with the Idaho Healthcare Foundation so that people can make donations to them and they can help us fund this program as well because they also saw value in what we were doing. So we do have this big goal of having this run itself and be funded by an entity that is not just myself personally, but as we go through and we look at what we were doing with this program, I hope that you can also see that there was a ton of value and a ton of learning, and we are not able to stop doing this just because the money ran out. The next thing we're going to look at is the timeline of our sterilization and stuff. It is an amazing change that you see. You can see over here on the left, you can see the sterilization room that I had. You can see that one of these rooms looks like it's in a guest room with a crib, and that's exactly what it was. We actually had some boxes. We were using cardboard boxes to store some of our things. We had this crib. It's really cool. My grandpa made it. We don't have any children, but we do have a crib, and the crib is really neat. And then we did have our trailer and our vehicle beforehand. And so you can see some of the things that we had beforehand. We also did use silver diamond fluoride before the grant, but we didn't use a lot of teledentistry. So you can see on this other side, on the right side, this is after we got the grant, and it just got exponentially better. Our sterilization room is an actual sterilization room. I know it sounds silly, but man, it's so nice that we have regular flooring and not carpet. Now, we couldn't use any grant funding to be able to do that flooring, but I was able to do the flooring outside of the grant funding because the grant funding was paying for things that I was having to pay for personally before. We got some nice organizers, and so many organizers. One would think that we were selling organizational supplies with how many organizational supplies that we bought, but it really helped us keep our stuff together by having so many of those little VersaStat containers and all of the different drawers. I mean, there are drawers upon drawers upon drawers, but that organization is really helpful. We got another sterilizer. We only had one sterilizer before because that's all that we could afford with the loan that I had gotten. But with the grant, we were able to get a second sterilizer. So if our sterilizer broke down, we would have 2 sterilizers. We were able to get an ultrasonic shaker. Before the grant, I was hand washing every one of the instruments and inspecting them with my loupes. And once we got the grant, I was able to use an ultrasonic, and I still inspect them with my loupes, but that just helps so tremendously much. And you can see the difference in the sterilization room where you're looking at doing the sterilization in that spare room versus now. This is still in my house. We didn't build a building or anything. It's still in my house, but we were able to make room for it and have the things that we need to do sterilization very well. You can also see that we were able to set up a whole nice setup in these facilities where previously we were going in with a very, very basic setup, and it's just so much greater. You can see the intraoral camera over here on the right because we did dive a little bit more into teledentistry once we were able to afford the things to do teledentistry, and once we were able to afford the people to do teledentistry. Some of our biggest costs were actually in people, and so the grant enabled us to expand our team, which we'll talk about in some subsequent slides, but you can just see there's a tremendous difference in the equipment that we have. Another really important thing that the grant enabled us to do, as we had mentioned, was expand our team. Before the grant, I had 2 assistants and myself, and I did all of my own cleanings. And then when we got the grant, we were able to expand, and we were able to add 2 hygienists. Jingjing and Holly were our first 2 hygienists, and they helped pick out all the hygiene equipment, they helped build the hygiene program, and most of all, they really showed the true value of having a hygienist on that team. Because when I was going out there with my 2 assistants and I was doing the cleanings and the fillings, I thought I was doing a decent job. It wasn't until I had the hygienists come out that I realized that they were doing a much better job. And so I was really grateful, because that not only helped us by having those hygienists go out, it also helped me realize that value in having that hygienist go out and do those cleanings, because that is what they're very, very good at, and it's nice to have them in that position. Terry joined us a little bit later on as our 3rd hygienist, and they are just excellent. We also had 2 caregivers that joined on board, and that was during COVID. We were utilizing hygiene students for our assisted oral hygiene portion of the program, and when COVID hit and we weren't able to get in, then we turned to the caregivers, and we had 2 wonderful caregivers that stepped up and really showed us the value of having somebody on your team that may not be a traditional member of the team. And it was through necessity that we learned that, and that's why I am grateful that we had this grant during COVID, even though it completely screwed up our timeline for demonstrating value and having financial sustainability, neither of which were we able to really do on paper and with numbers. But we were able to learn some very, very valuable lessons, especially with interdisciplinary collaboration. So you can see that we were able to work with a student every year of the grant. We were able to have a student from the College of Southern Idaho hygiene program. We had 1 senior come out each year, and they came and provided assisted oral hygiene or guided oral hygiene, depending on if it was a pandemic or not. And it was absolutely wonderful working with these students. These students brought so much to the table. They all helped us innovate. They all helped us learn. And it was wonderful for them as well, because now they're in practices and they have so much more of a deep understanding of what caregivers go through. So as they're working in their respective practices, they're really going to bring a lot to the table to those practices. And I'm very proud of each and every one of them for the work that they did with us, and also taking that into their other practices. Of course, after the grant, we have a little bit smaller of a team, and that's because we've cut down on some of the services that we offer. I am no longer going out into the long-term care facilities and providing the professional dentist services anymore. We did want to keep the hygienists out there. We did want to keep the assisted oral hygiene program out there, and when we had to make a cut and we had to cut something, I chose to cut myself out of there and to continue on with the assisted oral hygiene and the guided oral hygiene. That was not a financial decision, because financially it would have been better off for me to continue going out there. It was more of a decision of what was important for the patients to continue doing, because with limited funding, we really had to say, what are we going to do? What are we going to cut? And even though what I did made more money for the practice, what the caregivers did and the hygiene students did with the assisted oral hygiene was by far the best thing we've done in the practice, and the hygienists were a close second. Like many things, our practice evolved out of necessity. I started the practice as a hospital practice in 2016 with the goal of treating patients who couldn't be treated in an ordinary clinical setting. I started seeing patients under general anesthesia in the hospital, and then I began getting referrals for patients who were too medically complex for me to feel comfortable putting them under general anesthesia to have them receive their dental treatment. With that, we decided that maybe if we were to go into some long-term care facilities and group homes, that they would be more comfortable in those settings, and we would get more behavioral compliance and therefore more success. And it turned out that worked pretty decently. We were able to go in, and these people were in a familiar setting, and they felt more comfortable. And since I was a strange person, but in a familiar setting, it wasn't quite as strange. And we were excited about that. We started working with Dr. Richard Bailey. He gave us some courses. He taught me a little bit about portable dentistry and some systems that he used, and he was wonderful and instrumental in getting started. And this again is still before the grant. And we started having a portable clinic with a couple of dental assistants where I would go out and provide dental care in long-term care facilities. We had a lot of long-term care facilities we were trying to take care of, and part of that was a little bit overwhelming because it was hard to keep track of who was where, and there's just a lot of stuff that goes into it, and so having so many facilities for me was more than what I could handle, but I didn't know that at the time. We also had developed the Your Special Smiles Oral Hygiene Ability Spectrum. The first time I ever presented that was at the Special Care Dentistry Association, and it was a few years before we had the grant. And we presented this system as this new innovative documentation system that would take into consideration the patient's ability to clean their teeth as well as their cooperation level. And a ton of thought went into how we could develop this system. Well, nobody ever used it. It was a great idea that was really impractical. And the reason it was impractical is because we would give it to the caregivers, we would teach them how to use it, but no one had any time for any of that stuff. So in our minds, it was a way better product than we thought it was. But throughout the grant, and we'll go through with the grant, we were able to make it so that it is very usable and it is a useful system. So the grant built upon things that we had already started, but it also took things and made them more functional. Before the grant, we also applied silver diamine fluoride and did smart restorations. That's been part of my practice almost since the very beginning of SDF becoming available widely in the United States. And so before the grant, we did do a significant amount of things that we did in the grant, but the grant made a lot of that better. So now let's look at what the grant added to our services. We were able to get what I call real hygienists. And so when I was doing the hygiene services, it wasn't quite as good because I'm not a hygienist, I'm a dentist. And I can do some hygiene services, but my hygienists do a better job at hygiene services than I do. And that was really made clear when they started going out into the facilities with me, and I was able to see what they were doing and see what a great job they were doing. We also started implementing teledentistry, and that was wonderful. I was able to have my eyes opened to how well I could see utilizing an intraoral camera, and now I don't want to do an exam without one. Even if I'm there in person, I will still take a video for that person's initial comprehensive exam. I don't do it for every periodic exam, but for every initial exam I also have a video, because I found that with the video my accuracy has just gone up quite a bit. And that's not only helpful in the teledental practice, that's helpful in a brick and mortar practice. That's helpful just to be able to see where my strengths and weaknesses were. Utilizing that camera was of tremendous value. Another thing that the grant really helped out with in the Department of looking at hygiene is our hygienist started applying silver diamine fluoride, and previously it was just me. I was the only one that was applying silver diamine fluoride, and why? In my mind, that was what we should do, is I should be the one to apply silver diamine fluoride because I was the dentist. And then through the grant and through working with these wonderful hygienists and seeing all of their skills and talents and capabilities, I was then very comfortable with having the hygienists apply the silver diamine fluoride as well, and that dramatically increased how much we could do and when we could do it. From there, the pandemic hit, right? And so out of necessity, we had to have the caregivers also be able to apply silver diamine fluoride because we couldn't get in. And so we did have to work with the Board of Dentistry, and there was quite a bit that went into getting it to where the caregivers could apply the silver diamine fluoride, but we were able to make that happen. Another system that developed during the grant program was our assisted oral hygiene program. When we're looking at caregivers providing regular oral care, so brushing and flossing of the teeth, there's some things that we really have to overcome. One of those things we had to overcome was those people don't have hardly any time. They have got so much on their plate when they're taking care of people, and they're getting called in every single direction, and it is just difficult to be able to get someone's teeth brushed when you're being pulled in so many directions at once. So that was one big problem we had to overcome, was the caregivers actually having time to do a good job. Another big problem we had to overcome was caregiver turnover. You would get someone trained, you would get someone to see the importance in oral hygiene, and then they would go and get another job. And so that was really difficult for us as well. And those were the two biggest things. We went out and we shadowed caregivers, and we saw hey, why is this not happening? Why are we not able to get the teeth cleaned? And when they come into the office or when we go out to see them, it just looks like they just ate a bagel sandwich all of the time. And we learned that that's exactly why, is that time and the caregiver turnover. So to conquer those two things, we built the assisted oral hygiene program. And the assisted oral hygiene program means that the person who's going to be providing those services at least once a week, the person who's going to be the leader in those facilities, is going to be a member of our team. And this started off with our hygiene students. So we had a hygiene student that would go out and she would see each patient at least once a week, and she would make sure that their teeth looked great at least once a week. She would go in with her brush, her floss, her proxy brush, all of those things. And we developed a whole training system to where we would train them. I had an exam for them. I had an oral exam for them. I would shadow them for a certain amount of time. And we would make sure that both parties were comfortable before they were let out on their own. But then they were able to go on their own to the facilities. We started off with them going out 3 days a week, and with the goal of seeing each patient at least once. They also were going to help with the documentation system and make sure that the caregivers were doing oral hygiene and were documenting it, because this was not a substitute for their daily oral hygiene. This was a supplement. So they were not serving as the provider of brushing and flossing teeth. They were serving as the leader in home hygiene. And so those are two very, very different roles that are important to be defined, because we didn't want the facilities to feel like, and this did happen, and we did have to clarify that, to feel like now they don't have to do oral hygiene anymore because we are there. We are there to help and to supplement, but not to substitute. And so that was our assisted oral hygiene program. Then when COVID hit, we couldn't have those students go out anymore because of the pandemic. Everyone was locked out. And so the students were then able to train the caregivers, and we had our hygienists get involved with this as well. And so Jing Jing was one of the main people who did the guided oral hygiene. In fact, I would say that Jing Jing was our main person in the development of the guided oral hygiene, and she really went out there and trained the caregivers. She even had a couple parking lot training sessions where she worked with the caregivers on dental terminology, on how to use the camera, on what to do, what are these different tools, and how do you use them. And through this telehealth connection, we were able to get into the facilities and work through the caregivers. And we had 2 awesome caregivers that were really, really helpful, and I mean, just really, really did a good job. And they were the reason that we didn't see as much problem during the pandemic, because they were there to help keep the teeth clean and to help keep our programs going even when we couldn't be there. And so that's the way that the services evolved while we had the grant. And then after the grant was over, we really had to look back and say, what is really important to us to keep? And the very most important thing for us to keep was the assisted oral hygiene / guided oral hygiene program. We were not going to get rid of that. That was where we saw the most results for the residents. And even though it is a very expensive program to run, because, well, we'll get into that later, but it is a very expensive program to run, it is a very, very worthwhile program to run. We also kept the hygiene services going, but we cut back to, instead of having a goal of going out every 3 months, we didn't always make it. Of course, with the pandemic, there were some years we didn't make it, but our goal was to have the hygienists go out every 3 months. And we realized when we didn't have the grant funding that was not a realistic goal. And so we were able to say, okay, we still want the hygienists to go out, but we're going to try to do this every 6 months instead. So the hygienists will be going out every 6 months, and we did cut my services. So I no longer go out to the facilities unless there's an emergency or somebody absolutely cannot come into the office and is bedbound or something of that nature. But we did cut out the services that I deliver because cuts had to be made somewhere. Part of the cuts were financial, just without having the grant, but another part of the cuts was that I started the Family Health Services Advanced Delivery Dental Clinic with Family Health Services and Delta Dental of Idaho, and a lot of my focus went to that clinic, and I didn't really have a lot of time to be able to go into these long-term care facilities and provide, a pseudo-comprehensive dentistry in those settings. So what we did is we changed it to where we are doing preventative dentistry, and then we are welcoming those patients with open arms into the Family Health Services Advanced Delivery Dental Clinic, or any dental clinic that they would choose. We would be happy to work with. So we want to continue this program. We want to make this program a little bit more inclusive for the facilities that we're working with. We started this program and we went through the grant with just a group of pilot program patients. And so it was not the entire facility. We allowed the administrators to help us select the residents that they thought would be good participants in this program, and we went from there gaining consent from their guardians. We would like this to be something that anyone who lives in the facility could participate in. And in the future, with the appropriate funding and the appropriate organization, I think that is a possibility. We also would need the appropriate staff. So our future team that we would like to see to cover the facilities would be 2 hygienists per facility. So each of these facilities we will estimate to have about 36 people in it. And so we want each hygienist to take care of about 15 to 17-ish people. We would like to have 1 student in each facility. So that would be doubling our number of students. And we would like 1 caregiver in each facility. And we feel like that would really help us be able to expand these services to the entire facility instead of just a select subgroup. The services that we're talking about wanting to continue on with are 6 months screening and scaling appointments. So the hygienists would do screenings and scale these patients and get all of the buildup off, or as much as they possibly could, of course. And then they would send videos, x-rays, and those kind of things to me where I would screen those patients and make sure they didn't have any urgent needs that would need referral. Another one of our goals is a referral. We want to have a really solid referral system and relationship with our local health center, and any dentist that's local that would like to participate in this referral system, we would like to be able to participate in the referral system where we could send that teledental information and we could get them into a regular practice setting or the Family Health Services Advanced Delivery Dental Clinic in my case. We want to provide an annual in-service. The in-services are helpful. Even though there is a high turnover rate when they are able to do those in-services, I do think that the light bulb does click on for some of the caregivers, and it improves oral hygiene, albeit for a limited amount of time. It is a useful tool, and we would like to do it every year. We would like to have our hygiene students do that, and so far we've been able to do that every year, and it's been pretty successful. We want to make sure that we can offer assisted oral hygiene to the entire facility. So that's another goal of ours, is to offer it to the entire facility and to have at least half of them accept it. And so that's where we would like to be in the next few years. That's where we would like this program to grow to, and that is our end game goal. After that, we just want to help mentor other people and have other people get programs like this. We're not trying to build a giant program that we would run. We're trying to pilot new ideas so that we can spread that out, but utilize other practices and other folks so that this program can be not just one practice, but in any practice that would like to in the state of Idaho or anywhere. This slide goes over the main takeaways that we learned from this grant. One of the things that we learned was that it takes a lot longer to brush teeth than we thought. We can see about 3 residents per hour with a trained provider, and what was really the case was 3 to 4 residents per hour with a trained provider. The thing that we don't think about when you're brushing somebody else's teeth is that there's got to be that little small talk. There's also got to be all of that PPE that goes on. And so it's not as simple like running in, brush, 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 brush for 2 minutes, run out, go to the next patient. And that's what people think about when they think about helping people brush and floss teeth. They're like, well, they're only going to be in there for a couple minutes. No, that's not true. You brush your own teeth for a couple minutes and can do a decent job, but that's really not an adequate amount of time to do a decent job when you're working with somebody else in a caregiver and recipient type situation. We found that it takes about 20 minutes per resident to do a quality job and to treat them as a human while you're doing that. So to have a little small talk, introduce yourself, how's your day, and then then go in and get that cleaning done. We also found that looking at this, the assisted oral hygiene costs approximately $70 per resident per month, and that is assuming that they're going to have their teeth cleaned and have a session 1 time a week. So $70 per resident per month, assuming that they also provide their own oral hygiene equipment. So that would be having at least 1 session per week, and they would provide all of their own toothbrush, floss, toothpaste, all of that would be provided by them. We learned that intraoral cameras are a great communication and education device. With our intraoral cameras, not only were we able to see and do teledentistry, we also were able to see where people missed when they're brushing and flossing. And it wasn't just us that could see that, the patients could see that too. So the patients really were able to see the problems as we see the problems, and that opened the patient's eyes into oral hygiene, or perhaps the caregiver's eyes. They were able to see, oh my gosh, there is a giant piece of tuna back here, like we need to get that out. And our caregivers really learned, and they learned very quickly using those intraoral cameras. One of the best parts when I was watching a video is one of the caregivers was taking a video to show me something, and the caregiver says, oh, look back here. You see that? You see that stuff down by the gums? I need you to brush that a little bit better next time. And then I hear the resident agree. degree and say, okay, and that's what we're looking for with that. We're looking for that type of education. We also learned that SDF works well in most cases, and that's something that can be done by a hygienist, by an assistant, by a caregiver, just about by anybody on the team can place the silver diamine fluoride, and of course that depends on what state you're in and what's legal. We did end up being able to have our caregivers place silver diamine fluoride, but it did take quite a bit of work to be able to do that, and quite a bit of work with the Board of Dentistry to be able to make that happen. I also learned that the dentist's most important role in this entire process was not at all the dentistry, but more so reviewing the medical history and writing down modifications based on that medical history. Just looking at that patient and assessing risk versus benefits of different things, and thinking, like, we're looking at some of this end-of-life care, so when we're looking at those kind of things, just looking at them medically and looking at them as a person, that ended up being a more important role for me than doing any of the dentistry. And so that was something that we really came into while we were working with the grant. We learned that this can be implemented in any practice. So just because we do it one way doesn't mean that somebody else can't do it a different way and still get very similar results. If I do go out to the facilities, I do like to go and see the patients sometimes. I'll go out and meet them. If there's an emergency, I'll run out there. I like to go with our assisted oral hygiene folks. I like to go out there with them the first time they're with every single patient. So the first time they get with a patient, I am also there. And that's just my personal preference. But if there was a dentist that wanted to stay in their practice and just have a hygienist go out into the long-term care facility, that hygienist could provide a considerable amount of services, and that dentist would have never had to leave the practice. They could supervise utilizing some teledentistry. They could have that patient come into the practice to do the exams. There's just a lot of diverse ideas that could go out with teledentistry, and we were beginning to see some of those ideas when we were practicing in these long-term care facilities. We also looked at this financially, and a lot of our patients were on Medicaid. And so when you look at it financially, the rates that Medicaid pays for these services, and actually the fact that they don't pay for a lot of the needed services, such as fluoride varnish for adults, that really made a difference in if this was going to be financially sustainable for that population after the grant ran out. And the answer is that it's probably not, because when a lot of the services that you deliver are not covered and these patients can't afford to pay a fee for service for these services, it really provides a challenge for us, because not only are we being paid a lower rate for the services that are covered, we are not being paid at all for the services that are not covered. And when we looked at it, it was like, well, this is why we call it selling Tupperware. We say, you're selling Tupperware. This is not your job. And that's the mindset of every person on our team, is that this is an extra thing that we do for the community. And yes, I do pay the team, but I can say that I don't pay them as much as I would like to pay them. And I don't pay them what they are worth, because we can't. We can only pay what we are reimbursed. We can't go in. Well, we have gone in the hole, so I can't say we can't go in the hole, but every bit in the hole that we go, I have to pay out of my speaker honorariums. And so we really have to be careful with that, and the Medicaid reimbursement rates are a large barrier for this type of care for those particular patients. Now, that said, not everybody has to take Medicaid, and there are patients that need help and need this type of help that are not on Medicaid, and a provider could make an excellent living doing this with those patients. But when we look at the population that are on Medicaid, and a lot of our geriatric patients do evolve to be able to qualify for Medicaid just based on the costs of being in these facilities, then it restricts the care for quite a few folks just simply with the funding. We just have to cut back to the very most basic services and only offer those very basic most services, because we have a hard time affording some of the others. If we were able to get silver diamine fluoride covered and fluoride varnish covered, I think this would be a very different conversation and a very different story, but it is not. And so those are some major barriers. Another powerful tool that was developed during the time that we had the grant was our website. Our website is a tool where we can have a much broader reach than what we can just here in our state of Idaho. Now, it's important to have this reach in the state of Idaho, and the purpose of the grant was to expand access to care in the state of Idaho. But really, when we're looking at the biggest barriers to care, which is the Medicaid reimbursement rates and what services are getting paid and what services aren't getting paid, we need to look at this from a more national level. We need to look and see, what are other states doing? Are other states interested in this? Is this something that we can create a national movement? Because that's how we're going to get people to be on board in our state as well, is when they start seeing success in other states. Maybe we'll be a leader. Maybe we'll be the state that does this first. Maybe we'll be the state that starts covering assisted oral hygiene. That I don't know. But I feel like the more this information can be out there, the more people can gather data. I am not a data gatherer. If you looked at any of my results from the grant, you're going to really realize that I am not a numbers girl, and I am not good at gathering data. I am good at coming up with ideas, and I am good at thinking of systems and how to work those systems, but I'm not good at thinking numerically. And so I feel like the more we spread this idea, then the more people who are good at thinking numerically, those people who can do studies, those people who can show this objective value, that's going to help these systems catch on, and that's where we're really going to be able to expand the access to care, is when you have those folks who are good with numbers looking at these systems, not just, your Special Smiles in these 2 little long-term care facilities, but maybe 13 people in the course that I gave, where there was 40 people in the course. 13 of them went back and started one of these, and one of those people works at a university, and they are going to write a paper with stats, and then they're going to have another person in the university, another university, read that article, and then they're going to do it, and that's how we're going to grow this, and that's how we're going to make it so that when my generation is in the long-term care facility, someone's going to be brushing our teeth. And that is the ultimate goal, is so that when we grow up and we are living in these facilities, that these types of programs will exist, and we will be able to have good oral health in our later years of life.